This is PopHealth Week, streaming live on Healthcare Now Radio. I'm Greg Masters, your co-host and executive producer, and joining me in the virtual studio is my partner and co-founder, Fred Goldstein, lead host and president at Accountable Health, LLC. PopHealth Week is your destination for unfiltered conversations with the visionaries driving population health forward. Whether you're a payer, provider, patient vendor, or policymaker, this is your go-to hub for fresh strategies and insights into population health management. Want to stay connected? Visit popupstudio.productions or message me on Twitter via @GregMastersMPH and follow at PopHealthWeek. To reach Fred directly, visit www.accountablehealthllc.com. Today, we're honored to host Dr. Thomas E. Dobbs, Dean of the John D. Bauer School of Population Health at the University of Mississippi Medical Center. Dr. Dobbs brings a wealth of experience from his extensive career at the intersection of clinical medicine and public health. Before assuming his current role in August of 2022, he served as Mississippi State Health Officer, where he led the state's response to COVID-19 pandemic and focused on addressing health inequities. Dr. Dobbs also holds a clinical position in the Division of Infectious Diseases, specializing in HIV and sexually transmitted infections, with a particular interest in the social determinants of health. Fred, let's delve into Dr. Dobbs' insights. The mic is yours.
Thanks so much, Greg. And Thomas, welcome to PopHealth Week.
Hey, thanks for having me again. It's great to see you.
It's great to get you back on. So we both just recently returned from a trip to Saudi Arabia for the second Rural Health Conference at Hafr al-Batin. Tell us your thoughts on it.
You know, it was really fascinating. I mean, in addition to really sort of like cultural overload, right? Because it was really just really a very rich experience. It was really fascinating to get to learn a little bit more about their health systems and their health challenges. A lot of it was really familiar to me. Some of the same health challenges that they're having, these sort of diseases of sort of excess, or maybe diseases of sort of sedentary lifestyles and excess caloric intake, they're really struggling with it. And then also seeing, I tell you what, I mean, there's so many things to talk about, but to see that how aggressively and how forward they are in thinking about how to address these things, I think there's a lot that we have to learn from what they're doing in the Middle East.
Yeah, I thought the same thing was fascinating. The problems are similar.
Yeah.
Maybe some of the approaches might be different given resources and things like that, but they're really struggling just as we are with issues like obesity and diabetes in these rural communities with access and contacts and getting a hold of folks and getting them involved. So I really enjoyed listening to the different thoughts on it, especially they also came from, individuals from South Africa, from Scotland and around the world to provide expertise, as well as those within Saudi Arabia. And you presented, because Mississippi obviously does a ton with rural health and the issues you have, in the telehealth center, which I think is one of 2 national centers of excellence.
Yes, that's right.
Yes. So tell us a little bit about that presentation.
Yeah. So I was happy to talk a little bit about things that we've discovered and explored around using telehealth as a mechanism to overcome disparities around geography, resource limitations. One of the things that we're seeing more and more is a concentration in healthcare technology, especially as it becomes more advanced in more urban areas, right? And so we're seeing, less and less availability of the high-end specialties or even basic primary care in rural areas. We've seen this big shift. And some of it's sort of inevitable, but some of it, there may be other tools we can use to sort of intervene. So I talked a little bit about, the layering of different levels of telehealth to try to meet people's healthcare needs, whether it's going to be using e-consults, bringing specialists to the primary care doctor so that they can treat more advanced disease locally, right, without having to make, long trips. Because a lot of times that's an easy thing to do, using more traditional sort of, video telehealth that we would do for patients remotely. And then also sort of more informal things like, telehealth communications through like text messaging and that sort of thing to maintain health. And also too, how do we use telehealth platforms or these community or sort of like community meetings under like the Project Echoes to cultivate local expertise so that we can basically leverage the existing local resources and make them maximally impactful while drawing on the richness of capabilities that exist in sort of more centralized centers.
And what is Project Echoes that you just mentioned?
Yeah, so Project Echo is basically sort of it's a regular group-based learning strategy. Initially, I think it came out of New Mexico, where they were training local providers on how to treat hepatitis C. A lot of times things that are actually not that hard are difficult to engage in locally if local individuals don't have experience, right? You have to have some level of experience to be able to gain that confidence to treat folks. And so how they started it out is they created a learning group of local providers, physicians, who then would work with the specialist, and they would have basically, kind of didactic sort of conversations about how do you do it. But then it's case-based, and they say, oh, I've got this person, and this is what I would do. And then, oh, yeah, you're doing that exactly right, but you might want to check this lab. And that way, it empowers people to gain skills to bring treatment that otherwise would require sort of a specialist referral. And there's a whole bunch of things that really are amenable to that sort of approach. And we've been doing that around sort of STD treatment and prevention. And that's really been great to sort of bring, especially with mostly we have like nurse practitioners and rural providers, to make sure that, they know what are the mechanisms to prevent HIV? How do you access the medications? How do you diagnose these things? And it's really been, it's basically a group-based empowerment exercise where we disseminate capabilities to areas that don't have it.
Yeah, so it's fascinating you should talk about that, because you think about telehealth and everyone thinks, oh, it's about, this patients can be in the rural community and they talk to the doctor or something. But it really goes from that early sort of education provided directly out so that provider can do something, all the way up to maybe co-managed cases to
Absolutely.
full-blown, okay, we're now referring this to you as a specialist to manage this case.
Absolutely. And, it's so different than didactic learning. Because you can tell somebody something, but unless they experience, unless they live it, and if someone can have the confidence to learn through the process with their own patients, right, with someone guiding them, I mean, it's basically mentorship. It's a video mentorship in a group setting, and it really is incredibly impactful.
And I know we had a little discussion kind of around TB and the work you're doing that. So can you talk about sort of that Southeast Network thing and that kind of stuff?
Yeah. So I'm real excited that I'm part of the Southeastern National TB Center, which is a CDC-funded tuberculosis expert group. And there's several things that we do. A lot of it's sort of educational, where we offer educational programming virtually and also in person sometimes to sort of help train the next generation of TB specialists, nurses, nurse practitioners, physicians, that sort of thing. But another thing that we do is we offer a thing that would fit within the description of e-consults, right? Because a lot of times if you're treating somebody locally and you come across a problem or a conundrum, if you haven't seen it before, you may not know how to deal with it. And so what we do is we actually have a referral line where a local physician, a lot of times it's an infectious disease doc, but since we don't have that much tuberculosis, not many people have a really long history and a sort of deep well of experience with it. And so they'll call and say, hey, I've got this person, they're on this medication, they're having hepatitis related to the medications. What do you do about it? That sort of thing. And if you haven't done it before, it's scary. But me having done it hundreds of times, I'm like, oh yeah, this is what you do. This is what you can expect. And sort of having that sort of communication and then longitudinal follow-up, say, yeah, and let me know how they're doing in a week. And then it really helps them take better care of folks. And it works really great for diseases. I mean, this specifically works great for diseases that maybe are not as common. And, but it's going to happen. And it really allows us to successfully treat people. And you can imagine the downstream benefits of obviously the clinical success for the person who's getting better. But like for tuberculosis, then they don't spread it to their family and their friends and stuff like that. So it's really a way to leverage resources and, sort of a limited resource, but it expands it to where it can be accessed, and I think we have like maybe 14 states that are within our network, all the way up through Illinois. It's not just Southeast. I don't know how they break them down, but it's also great fun working with the doctors all over the country.
And how broad is that telehealth program at UMC?
Well, the UMC program is actually very broad. They've got a really phenomenal complement of telehealth capabilities. They have the traditional telehealth, urgent care sort of stuff. You call in and, get taken care of. We have a lot of telemental health. And telemental health is fantastic because, you can do conversations, people can access from home and overcome some of those transportation barriers and that sort of thing. That's been super popular to be able to do. We do a lot of tele-MAT around, substance abuse, opioid, getting on medication-assisted therapy, primary care. We do remote patient monitoring as far as like, helping people with hypertension and diabetes, making sure that they're, able to, do well with the parameters of their illness. And then there's another neat thing that actually my wife is doing now too, is they have tele ICU.
Wow.
She's participating in tele ICU such that they have board certified intensive care unit docs who will do tele ICU for more remote hospitals so that they don't have to try to send people out if they don't have to. But also too, we have a congested healthcare system where sometimes you can't get people transferred. And just it's another layer of support to make sure that we can provide, more advanced levels of care and expertise for people who have those experience, that sort of depth of experience in those circumstances to bring resources local.
Mm-hmm. Yeah, fantastic. And I always think back to my mental health days when you talk about telemental health. And remember, in the rural communities, we used to see difficulties with getting individuals in to see the local counselor because they didn't want their car in the parking lot.
Yeah,
So
that's
to
true.
be able to do that from your home, have a
Yeah.
professional licensed therapist, and do it that way obviously helps with that issue as well.
And we're so used to now telecommunications like this, like, you and me talking, it seems so natural.
Right.
It's actually it's very normal nowadays. And being in the comfort of your own home and be able to communicate with somebody without having all the stress of traveling and parking and people seeing you, it's great.
Mm-hmm. And so were there any other things in Saudi Arabia that you found interesting, surprised you, didn't?
Yeah, so I mean, a lot surprised me, right? So from a health perspective, I think the prevalence of obesity, excess weight, diabetes, hypertension, I mean, you can just see it in their eyes. They just see this blooming public health disaster on their hands, talking to the docs like Saad, our colleague. So I was surprised by the magnitude of that. But culturally too, I think one of the things that surprised me is it doesn't seem like it's a culture that has yet embraced the need for additional intentional exercise. Because you and I went for a walk with our friend from Scotland, but it wasn't really an easy walk.
No.
Yeah.
No. And I remember I had another trip a couple of years back to Kuwait, and they talked about the fact, obesity, I think there was just enormous as well, that it's so hot in the summers that they go from their AC home to their car to their office to their car to their home and never do anything else and get outside. And so, yeah, obviously difficulty, in the area we were, obviously it was a lot cooler this time of year, but
Right.
that whole idea of how you inculcate a culture with doing that kind of stuff is difficult.
Yeah, and I think that's something that they'll have to be thinking about is, you've got to integrate some physical activity. I mean, diet modifications and that sort of thing are obviously critical, but our human body's made to move.
Yeah, and it's tough when you're driving through and you suddenly see the McDonald's over there,
Yeah.
or the other things that we've exported to these countries.
Yes.
And they have an opportunity to spend time and eat those kinds of things and go at it. So
What surprised you, Fred?
I think the issue about obesity has been a big one, and then like you said, the idea of how do you then start solving this? I think the country from I like their 2030 plan, which I've read a couple times now
Yeah.
around healthcare and
Yeah.
this idea, and they're making progress where they've gone from 72 years of life expectancy to 77, but their goal is 80 by 2030. And what also surprised me that we don't see as much here, I don't think, was one of the four areas they want to work on is actually automobile accidents, which
Yeah.
is one of their leading causes of death. And you can see it when you drive around that country. There's these open roads out there and you can just go, I think. And I did have one crazy experience with a driver from the airport on a prior trip who was just going around vehicles on the side lanes and stuff.
Oh, heavens.
And
Yeah.
so, but they're working on, I think what's good is they've sort of got this, for better or for worse, they have this centralized ability to try to do something.
They
And
do.
I think that helps in some ways. And sometimes that can hinder you as well. But I think that setting that plan out there and that goal and then just driving towards it. I'm always surprised by the expertise. The people who we met who've been in our program, in the program you're the dean of, have multiple degrees already, and they're coming back and getting another master's in population health or something like that. So
Yeah.
they've really looked to up that capability of their group, and I was very impressed with many of the speakers. They're really they understand it. Now the question is obviously making it active and doing it.
Just tuning in, we're here with Dr. Thomas E. Dobbs, Dean of the John D. Bauer School of Population Health at the University of Mississippi Medical Center. Stick around, you won't want to miss the rest of the story.
Yeah, no, absolutely. Getting across the finish line, but they are paying attention to it. They really are.
Yeah. Yeah, so that was really interesting. Obviously, I enjoyed every time I go there. The food's great, and
Food, it was fantastic. And the hospitality was really
unbelievably nice. Yeah, incredible group, and getting the opportunity to interact with some different thought leaders from around the world is always fascinating. And so that was great. So obviously, you've been in your position now as the dean for a while.
well.
How are things going at the program? What are you trying to do next?
I think things are going well. We have several sort of strategies, and I think one of our big strategies is make sure that we sort of expand our population health management course, make sure that it can benefit more people. Trying to work on improving the quality, making sure what we do have is an executive master's degree in population health management, and this is something we really see that sort of can help people, maybe early professionals or mid-career professionals, or even maybe more advanced, to sort of add a new skill set or a new sequence of skills to advance and accelerate careers, and to sort of impact health where they are, whether it's going to be a health system. And that's a lot of people, who end up becoming, health system leaders. And we've seen some of the people who've taken our courses have gotten pretty substantial promotions, right? Because they've added those skill sets around, data analysis, around understanding how to manage and approach health from a population perspective, right?
Mhm.
And also too, technical skills, where they can do more advanced analytics and understand the logic of why things are not working the way they should be. And then also there's a lot of, obviously, of health system wisdom and understanding, because health systems are complicated, especially in our country. And to learn the rules a little bit so that you can know how to win the game.
Uh-huh. And I know there's, obviously the executive program for those individuals who are already in the field and do it sort of after hours, things like that. But there's also a regular master's as well as PhDs as well, and multiple departments within the school, right?
Yeah, no, we have multiple programs. We do have a PhD program in population health science, which is going to be, like analogous to a PhD or DRPH, public health. We're, that's a pretty small group, but they're going to be highly technically skilled and academics. We have data science and biostatistics, some AI work, and, more traditional sort of, biostatisticians. And then also we have a master's degree in population health science, which is going to be analogous to an MPH, master's in public health, where we're really training people to be public health leaders, both, at sort of operational level, but also to elevate their careers so that they can be more impactful, whether it's state government or, traditional healthcare.
And you really brought a strong public health background into this department. So how do you see that playing as the department goes forward?
It's been good to have the experience of running a health department. I was over the state health department for a while, and also been working in public health for a while. But I've also, I was a health system executive for a while too, so I kind of get to see that a little bit. Well, and I think it's been really good because one of the things is people don't really talk about population health much here. It's a little bit of a foreign concept. The public health sort of hop, skip, and a jump makes it easier for people to sort of understand where we're trying to go. But also, too, a lot of the mechanisms for trying to improve health are located within health departments and other government agencies. And these connections, we understand sort of what the skill set people need to augment so that they can be more effective in those roles. And also, too, we can connect people with the health department and other agencies where they can get those internships, those practical experiences. Or if they even are at the health department, we can sort of like, hey, I need to learn how to do this, and we can make that happen. So I think there's a lot of a real good collaborative potential there that we want to build on.
Yeah, I think it's fascinating. When I founded my disease management company back in the late 90s, it was a community-based approach. And people came up to me and said, "Oh my gosh, what an innovative model." And I said, "Well, actually, it's the public health model from the 50s." So I didn't come up with it. And it's sort of been a forgotten thing in times. The ability, what public health has done around this country over the last 70 years or something has been amazing when you think about the impact it's had on our lives.
And in my public health experience, it's really interesting to think about, what is old is new again, sort of thing. Back in the 50s and 60s, we had these public health nurses that were community based, and they would go house to house, and they wouldn't have patient files, they would have family files. they saw it as sort of like a comprehensive unit, making sure that they're all taken care of, whether it's shots or access to food resources or, reproductive health. Thinking more holistically, and I think, expanding it beyond that, right, from the family, but also to the broader community. I mean, people's health reflects the communities in which they live.
Right.
Right? And as hard as we try to help individuals within the communities that have major challenges, we don't do very well with that, do we?
Yeah, and people always say, "Well, population health, you got to move this population." Well, you do it one person at a time,
Yeah.
but you've got to think broadly. And I'm wondering if we can get to that point where we sort of bring public health, population health, and the healthcare system all into one sort of fold
That's
to
ideal.
look at the entire system, and then begin to allocate resources that way on a much broader basis.
And I think kind of circling back to our Saudi Arabia experience, I mean, I can see where maybe they'll be more easy for them to do it since they have sort of more unitary control, over
Mhm.
all aspects of, but they have clear objectives, right? But you can see how they have these challenges, right? But in the community level, if we're looking at producing healthier food and having sort of like green pathways to walk and opportunities for healthier living, and because we didn't see any parks,
Right.
you know
We
there
we
was.
almost tried to walk to one, right? But it
Yeah,
was like 3 miles away or
yeah,
something.
yeah. And then once we drove past that park, and
Hmm.
when we saw it, it was basically just like a barren area with some sidewalks sort of in sort of twisty patterns. So, and it wasn't
Hmm.
any trees or anything like that. So yeah, I mean, community is the key. Community is the key.
Yeah. And you wonder if there's a way there. Obviously, you've got the whole geographic issue of where they're located and the weather and the landscape and everything, but maybe you build it inside. I don't know. We've seen that with some of these malls around the country that are
Oh yeah,
amazing
yeah.
places, and then you have the walking groups
Mhm.
doing it. Obviously, each country has to do what's culturally appropriate for them and
Right.
fits their culture, and then figure out how to build that out and message that out to. So it's an interesting problem for sure.
I'll be interested to see how they choose to address it.
Yeah, absolutely. You brought on a number of new faculty as well, so I guess that's a good sign.
Yeah, and we actually have uh, one of our new faculty members, Dr. Bahela, is actually from Yemen, has family in Saudi Arabia. So as if we set up some more partnerships in that area, I think he could be a real resource. Um,
Hmm.
you know, language barrier and all that sort of thing. We have Dr. Tyrone, who's a former student, is here now. She's a specialist in speech therapy and also child health issues.
Wow.
Dr. Bahela, I mean, Dr. Yande, who is chronic disease. And so we're building out our portfolio of specialization such that we can cover. We have a vision to sort of make sure that we have strength within huge component areas of health challenges with maternal child health. We got a big component, HIV, STDs, tobacco control, and tobacco related issues, chronic disease, children's health, ACEs, all that sort of stuff. So I'm really proud of the faculty we've got pulled together.
Yeah, it's been fascinating and fantastic to watch it grow as you've come in and it's beginning to move that direction. And is there one of the things I've always wondered is, and I know I thought I saw something about one university or something like that, some program they run. Are you beginning to see an interest in integrating the approaches of population health into the medical center itself?
Yeah, so that's actually one of the more exciting things because people are coming to us and we're adding some value, I think, to the medical center. Um, One of the obvious areas is, you know, we as a country, and I think, CMS and Joint Commission accreditation bodies are recognizing health-related social needs and social determinants of health as key drivers of health outcomes, which I think is not really surprising to us at all, but now it's becoming part of our compendium of strategies is to address these. And so we're working with the hospital to
Hmm.
to address health-related social needs to improve health outcomes, whether it's transportation or food insecurity. Housing insecurity is a really tough one, but we're looking at it. And we actually have a thing called the Murley Evers Williams Institute for the Elimination of Health Disparities here, which is basically a social needs clinic where we do work on these things. And so we're partnering with OB to help high-risk moms make sure they can make their follow-up appointment, right? Um,
Hmm.
so that's really integrated. We're working with the medical school more and more. They're interested in gaining additional skills. in that area. We're setting up group-based prenatal care in our Evers Care Clinic or MUI Clinic, where we can help. Maternal child health is huge, especially supporting women during pregnancy. I think has been recognized as a major area of need, and we're really, I think, going to be at the cutting edge of that, and excited to be able to make those contributions. But we need those partnerships with the obstetricians, right? We can't. That's not something we can do. We got to have these partnerships.
Yeah, I think that clinic is fascinating and fantastic. I've had an opportunity to go out there, meet with some of the folks, and look at what they're doing. And it really is critical. It was funny because I was looking at something on LinkedIn the other day where somebody was talking about the disparities in maternal health and children, at birth and things like that, and said, well, we really can't fix that. And I thought, yes, we can, but we got to
Yes.
move way upstream. We got to go upstream and get it early and begin to, and solve that. And I think that's exactly what is being worked on. So it's fascinating to watch.
Yeah, hopefully we'll continue to make some headway, and we're excited to have really strong support from the university.
Mhm. Well, that's really fantastic. Where do you see the school in 4 or 5 years?
That's a really good question. We see ongoing integration. There is phenomenal interest in sort of insinuating the skills and the training that we have in the medical school. So we've already got a contingent of medical students who are in the training program, and so that'll grow. And I'm glad to have more. I really would love to have more population health minded public health physicians out there. No matter what you do, thinking about things more broadly, especially from a population perspective, is going to be the key. So that's one thing that's going to be big. I see us sort of expanding our research footprint, being a lot more impactful. I see us doing a lot more implementation science, where we're really at the forefront, bringing forward, how do we make the evidence-based things like centering pregnancy, that group-based prenatal care, how do we make that successful? We're doing a pilot project now, but we would love to expand that statewide, right? We know that the evidence shows it reduces, preterm birth by about a third. I mean, that's phenomenal, if we can implement it right. So I see us doing more and more of that, and trying to strengthen up our student base so that we can have that sort of wave after wave sort of impact by making sure that we propagate these skills through the next generation of leaders and learners.
Well, fantastic. I want to thank you for all you do. It's really an honor for me to be a part of the department and to teach my class. It was great to go to Saudi Arabia with you and get an opportunity to learn more about what you're doing and what's going on. And so thanks again for joining us.
No, thank you. And we are so appreciative of having you on the team.
Thanks. And back to you, Greg.
And that's a wrap for today, folks. A big thank you to our global audience for tuning in, and an extra special thanks to Dr. Thomas E. Dobbs for his invaluable contributions today. From his leadership during the COVID-19 pandemic to his ongoing efforts in addressing health disparities, Dr. Dobbs' dedication to advancing public health is truly commendable. To learn more about Dr. Dobbs' work, visit the University of Mississippi Medical Center's website at www.umc.edu. If PopHealth Week resonates with you, we'd love your support. Give us a thumbs up on your favorite podcast platform, share it with your network, and do subscribe to ensure you'll never miss a future episode. Remember, we're live on Healthcare Now Radio every weekday, 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. You West Coast listeners, you can tune in at 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. On behalf of Fred Goldstein and myself, Greg Masters, stay safe, stay tuned, and we will catch you next time.